Hello everyone and welcome to our webinar, A Case Conferencing, a Model of Wraparound Care. My name is Dr. Robert Ward and I'm a full-time GP in Geelong and the father of a 26-year-old with intellectual disability, and I'll be the facilitator for this webinar tonight. So I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience and ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past, present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. And we support self-determination for First Nations peoples and organisations. So just a little bit of housekeeping briefly. The majority of our webinar events are recorded and freely available on the PHN Learn YouTube channel. We will put a link to access this on the webinar events and into the chat. And there's also listed upcoming events. I think we're getting to the end of the year, so that's going to be an interesting list for us. Please make a note that the Westvic PHN Health Pathways relating to the topics of intellectual disability is on the screen at the moment, and that's a really valuable resource for anyone looking for assistance. Particularly, it's nice and quick to access during consultations and afterwards from a local perspective. The West Victorian PHN also wants to understand the needs of the communities that they serve, and the 2024 needs assessment consultation process is underway. So please follow the link and tell us what health issues are most important to you and your community, and see if the Westvic PHN can help. All right, so if you've entered this webinar not displaying your accurate information for your first and last name, please type your name into the chat box. Only the administrators will be able to see this. This will ensure that you can have the correct certificate of attendance. So for this evening's webinars, all participants will remain on mute. And if you have any questions, please type them into the Q&A box and I'll ask them on your behalf to the presenter during the Q&A time. There's a link in the chat box to complete a survey after the webinar, which will also automatically appear when you leave the webinar tonight. All right, so our subject today is case conferencing and a model of wraparound care. I think we've learned over this series of webinars that providing healthcare services to people with intellectual disability is often quite fragmented. There's often many people involved. They may not communicate well. And there's also different funding models paying different parties looking after people with intellectual disability. And for GPs who are running true general practices, it may be even hard to have the time to sort out what's the best approach and how we can best offer services to our patients with intellectual disability. So I'm really pleased tonight to be able to introduce Heather Miller. Heather's a disability practice nurse and helping support patients with intellectual disability access primary health care. She's worked in disability services for over 20 years, including community learning disability and nursing in the UK, and supporting GPs to manage health needs of people with complex health conditions and intellectual disability. She's also had medical undergraduate education in intellectual disability and currently works in general practice as a disability practice nurse. So I hope to get some really good tips from Heather tonight about how better I can organise my practice to help my patients, and look forward to your presentation tonight. Oh, no, I'm going to hand over to you, Heather, so thank you.
No worries, thanks, Robert. Now, can you see that that screen share there of the presentation?
That's all coming up well.
Lovely, excellent. All righty, thank you so much for that lovely introduction. All right, so yeah, just as you're probably aware, I'm part of an amazing team, a very small part of it. So we've got Kerry and Nicole who at Spider, who've been driving a lot of the work that I've been supporting them with. So I just wanted to start with sort of the learning outcomes for this evening's session. And it's just looking at understanding the value of case conferencing and integrating and multidisciplinary healthcare when we're supporting people with intellectual disability and their health needs, and just understanding how you arrange a case conference, identifying the relevant professionals that are involved in the process who are supporting patients with intellectual disability, and from that looking at based on comprehensive health assessments, and I will be talking a little bit about that later on. and also chronic disease management plans too, so care planning. I'm going to be looking at how understanding how to lead and facilitate a case conference in your work setting, and how you actually document the actions for that, and also just learning the case conferencing workflows and processes, and basically tailoring it to patients' needs, looking at it through a quality improvement lens. Okay, so I think for me, working as an intellectual disability nurse, the work that we do, particularly in primary care, it's around that preventative health. And I think comprehensive health assessments, care plans, case conferencing, they all fit very nicely in being able to reach that goal and manage someone's healthcare needs. And this whole package, I suppose, it's around looking at preventative healthcare rather than reactive healthcare. And we know that we working with this population, plus other vulnerable populations, is that often it's reactive care that we provide, and we do see people that come to us in advanced stages of disease. And so this process is looking at ways in which we can reduce that and flipping it on its head and making sure that we're able to provide that preventative health care, because you don't work in isolation as a nurse or as a GP or in allied health. You work part as a team, and I'll be talking even externally outside of healthcare as well, that you're in quite a big major team in supporting the health needs and also health needs of this population of people on this slide. Okay, so as I said, I'm going to be looking at the tools that you can use to help support your case conferencing within your clinic setting. And we're going to start with looking at comprehensive health assessments, and that is basically identifying, we use that tool to identify what the health needs are. We use it to gather information, determine a baseline for that individual's health, and also their social networks, their supporters, and those sorts of really important areas. From that, moving on to care plans. Also looking at team care arrangements and how that forms part of the case conferencing process, enhanced primary health care, and also looking at how you work as a multidisciplinary team within a case conferencing framework. And then I'm also going to talk a little bit about NDIS as well, because they're not separate. They actually do interlink, and I'll be explaining why. And it's particularly around the fact that people do have disability-related health supports and require, and where that would fit in terms of the case conferencing pro forma framework. Okay, so you had this the other day, so I'm going to flick through that. So basically what I want to sort of look at first is, no, I think I've skipped too far, apologies there we go. So I'm not sure how much, and please feel free to pop anything in the Q&A box, because I know Robert's going to be having a look at that, and I'm more than happy to answer questions as I'm talking as well. Because often it's good to, sort of work with it here and now while I'm talking about a particular topic. But comprehensive health assessments. So Professor Nick Lennox, quite a few years ago, actually developed the comprehensive assessment health program. And it is basically, it's what it says it is. It's a very comprehensive health assessment that's been developed specifically for adults with an intellectual disability. It's evidence-based, so he's actually got quite a bit of research data from the effectiveness of this assessment tool. And it recently became available through the Department of Health, who purchased it from Nick's service to make it available freely for GPs to access, for family members, disability support workers, disability services to access, to ensure that they're meeting the health needs of the people that they're supporting. So you can actually just use this little QR code there, and that'll actually take you to the Department of Health website where you're able to locate it. In terms of Medicare, to actually claim for completing an annual comprehensive health assessment, the person has to be physically attend the appointment. And it's really important to encourage when they do book in to do it, when you're doing an annual health assessment, that you that someone, if they need someone to support them, that it's someone that knows them well. So it may not necessarily be a family member. It could be their key worker in their residential service. It could be someone at their day program or their place of employment. But it's really key. Literally, only last week, a patient of ours was booked in to do her annual health assessment, and she was brought along by a carer that had literally only had met her 15 minutes before coming to the clinic. So we were not able to do it because there was no one there to help inform and support her with questions about her health needs. And there was, even though we know her well, her expressive communication is quite limited, and that she has a mental health condition where she's deteriorating, so it was going to be a little bit harder. So we needed someone there to support her well. So that's really key to being able to effectively complete an annual health assessment. So if the person's not able to answer the questions, that's okay. Their representative person is able to do that on their behalf. And really, they're a great source of collateral history and information, and that can really bring in that sort of information that can help inform you with the health assessment. It's not a health screening service. And if the patient doesn't have the capacity to understand, many of the patients I support have very complex physical, intellectual disabilities, and as well as complex health needs. So many of the people that we support in our clinic are not able to express how they're feeling, or if they've been in pain or what have you. So that's why it's really great to have someone there that knows them well, and to have that person then provide that information on their behalf. But we do encourage the person as much as possible and include them. You know, that person-centered care is really important. Okay, right. Now, the reason why I put all these words on this slide is it pretty much covers all the areas of the health assessment. So you've got your hearing, bowel, immunisation, all sorts of things. Now, we know that particularly for people with intellectual disability, they're more likely to have health needs relating to abuse, so sexual abuse or physical abuse. We know that they often appear in dental clinics with, you know, advanced stages of dental decay, gingivitis, those sorts of things. And so it's really important that we look at these individually, but we also look at them in partnership as well. So for instance, people with intellectual disability are more likely to experience polypharmacy and are on quite a few medications. And those medications, particularly, say for instance, they have epilepsy, we need to be looking at, okay, if they're on anticonvulsants, we know that increases the, you know, their risk factors for osteoporosis. So it's important that we look at the person's bone health and fracture history and those sorts of things as well. So it can help inform to ask those questions. And again, knowing that person well, that they can provide that information really helps. Activities of daily living. So for, say for instance, people with Down syndrome who may be in their early 50s or in their 60s, you know, we will be really looking at those particular areas, just because, you know, over the last 12 months since they last had their health assessment, has there been a deterioration in their activities of daily living? That may indicate that they've developed a mental health need, say depression, which is more likely in the Down syndrome population, but we also know that early onset dementia. So we need to be looking at, okay, is that something we need to be exploring further? So that's why, you know, that's an important area within the comprehensive health assessment. So etiology is another one. So we, you know, particularly now with genetic services, and knowing that with testing of genetic conditions, we will do that every 3 to 5 years, depending on the patient. So we'll do a microarray. And really what that does is it just informs us whether there is a genetic cause for their disability. It means that we can then find out where that part of the genome is affected, and therefore we can look at, okay, what bodily systems are affected. So we need to, you know, that preventative care, looking at, okay, they're more likely to have cardiac conditions, or they're more likely to develop a mental health need, or what have you. So that's something that helps inform and guide us from each time we see the person, or from year to year with the annual health assessment, just to see if there's any changes. And etiology also helps inform that, say, for instance, Down syndrome, that we know that people with Down syndrome are more likely to experience obstructive sleep apnea, more likely to develop celiac disease or gastrointestinal conditions or respiratory conditions. So those sorts of things we'd be looking at in particular as well. So lots of stuff there, and as you can probably appreciate it, we when I say we, the nurses in the clinic that I work in, we do the health assessment. I'll be talking about this in a little while, but they take around 90 minutes. So and sometimes the person may have to come back, or we may only be able to see the person for a certain amount of time. The doctor will examine them and they need to leave just because they don't like being in the clinic for very long. They get upset or what have you. So we just make those reasonable adjustments, and I'll be talking a little bit about those later. Okay, so this is the MBS. So in terms of being able to claim a comprehensive health assessment, it needs to show that you've collected information, so the history, any investigations that you've undertaken, examinations and what have you, any investigations that you're wanting to put forward or are required for that individual. You make an overall assessment of the patient and their health, recommend any appropriate interventions, and this is where you can start to see, okay, you know, we found some health needs here, we need to refer out. Okay, we're going to get the services and the professionals and whoever's going to be involved in delivering that support. They're going to then start forming that case conference, that multidisciplinary team for that individual. So keeping a record of the health assessment is a requirement for a minimum of 2 years in the patient's records. And also you have to provide a patient with a summary of the findings and the health action plan to be able to manage the outcomes that you found from the actual assessment. And then offer a copy to the patient's carer. And then you may only be providing certain parts, you might provide all of it. It really just depends on the situation or to the person themselves. Okay, so it can only be claimed by a GP. However, health professionals, including practice nurses who are trained and have a knowledge in disability or facilitating a health assessment, are able to collect information and support the person through that process. And they need to be associated with the health service in which the person is visiting or is accessing. So it may include information collection, providing patients with information. So you may be saying, look, I'm just going to measure you here, and the reason why I'm doing that is this, and you might provide them a leaflet about something. It just depends, and I will talk a little bit later about making health information accessible for people with intellectual disability. And basically you're guided by the GP in your nurse role in supporting the person. The role of the GP in the clinic that we have is they come in and provide all the the eye, the hearing, the the respiratory, cardiac, bowel, testicular checks, breast checks, things like that that you'd expect a general practitioner to do. So I'm just going to play this video. This is Nick, and he just provides an overview of the health assessment, the chap.
Hello, my name's Nick Lennox. I'm a general practitioner by training, and for 30 years have worked with people with intellectual disability, providing healthcare and also doing education and research. My team has developed a health assessment tool called the Comprehensive Health Assessment Program, or CHAP. And the CHAP has been proven using the most rigorous scientific evidence to pick up unmet health needs in people with intellectual disability. What we know is that there is lots of unmet health needs, particularly in health promotion, disease prevention, but also diseases that are missed and poorly managed. And the CHAP addresses some of that. So it's really important that this process is done to improve the health of the almost 500,000 Australians with an intellectual disability. Now, looking at the CHAP, the way that it achieves this outcome is that the first part gathers the person's health story. And the health story is really crucial. It's absolutely crucial that we know all about your health journey, whether you've had a cough in the last year, for example, what your medications are, a whole bunch of other things that may have happened to you, any past diseases. And it tries to gather those in a way that it's accessible for the GP with the practice nurse if possible to review the health. Then in the middle of the tool, it actually has a list of the commonly unmet health needs. And this is to inform everybody involved, because it's important that people with intellectual disability and their family and supporters and the GP and practice nurse know where things can be missed and can direct their attention to try to pick up those things if that's true for the person they're seeing. The second part of the CHAP is filled by the GP and supported by the practice nurse. And the second part of the CHAP supports them to look at all the possible unmet health needs and provides some information as well. Once that is done, then there is an action plan where there's an agreement between the person with disability and the people that are supporting them, if that's the case, and the GP and practice nurse about what needs to happen next. Now, for disability support staff and people with disabilities, this may mean going and getting your teeth checked or getting your hearing and vision checked. It may be going and getting an investigation. And so it tries to deliver those things. It also may be going to see a specialist or an allied health professional. So it tries to do a whole bunch of things in terms of decreasing the barriers to healthcare, and we know from the research that it actually achieves that outcome. Thank you for watching this video, and please engage with the process of the CHAP, as it will provide a framework of care and a way forward for people with intellectual disabilities, their family and supporters, and their healthcare providers, and try to diminish many of the barriers and lead to a better health outcomes. Thank you.
There we go. I knew that had happened. Sorry. Okay. So I think Nick summed it up much better than what I have so far. But yeah, it's really the focus has been making it freely available for people with intellectual disability, their family, the carers. So it's a real team approach. And it's really is a shared responsibility between health and the disability sectors. And it's also a priority. I'm not sure if you're aware of the national roadmap for improving the health needs of people with intellectual disability as well. So the fact that you're utilising this tool to help with the work of the national roadmap, yeah, I think it really is key. So, okay. Now, you may not be aware, but for those of you who have worked in disability or working in disability, there's a lot of siloing that goes on. You know, you have amazing services and supports that are happening in certain areas, but they don't always communicate across those particular services or platforms. And I think what comprehensive health assessments and care plans, team care arrangements together leading to case conferencing can really help break down those silos and bring them together. You know, case conferencing is that tool that helps manage the health needs of people with intellectual disability amongst all the different services that are supporting the person's health needs. I just want to show you this video. It's a video from the UK. They refer to as multidisciplinary teams, but I just like hearing what they have to say, because in essence, this is what we're trying to achieve with case conferencing in primary care, and it just fills so many gaps. People get to know what other people are doing, what skills they bring to the person's care. And it just helps reduces, you know, really important things such as information, assessments and that can be missed when people work in isolation. So I will just
While Dad was in hospital, the amount of times I said to people, I wish that the left hand knew what the right hand was doing, because I was totally confused. I was absolutely confused with what people knew and what people didn't know.
The MDTs are the multidisciplinary team meetings, and the patients that we choose generally are the more complex patients that have complex needs that are not necessarily met by a GP alone looking at the patients. You'd need the wider primary extended care team.
The value of multidisciplinary team meetings is really, really great. The fact that all professionals can come together to discuss highly complex cases for each and every professional to see, identify their role and see how to help and move the cases forward, it's very important.
That's what the MDT can do. If these patients know that their cases are being discussed, they feel that they count. They're not just a name on a list. They're people that other people are caring about and want the best for.
I think it's quite useful to work health and social care together because it's integrated now, and we can share the information so that we are not duplicating the same information again and again, and also it is time efficiency. When the referral comes, we quickly pick on the referrals and meet the client's needs and work as a team as a health and social care.
I think the value of the MDT really is that we're so many different healthcare professionals, and we all work in different areas. We all have very different skills, different experience, and we can all help each other.
I think the MDT provides a good platform to discuss holistic needs, because you're looking at the patient from all different angles. So it's not just the medical side, it's not just the social side. It's like putting it all together to provide a package of care.
My role is to coordinate and liaise with practices, GPs, London Borough of Newham, CCG, all sorts of admin staffs and communities involved in making sure MDT meetings go the way they should.
We're very much more aware of what's going on in the community. A lot of the time as a GP, all I see is the medical side of things when patients come in to see me. So now I get feedback from the social workers and different members of the team. So I really feel that that helps with integrating care.
I'd say that the MDT meetings are making me more confident in my service and my own profession and the care that I can give to people, because I know that if I come across a problem, I can bring it up at the MDT meeting.
Yeah, I think a lot of our patients just need that human touch, not going to hospital all the time. Yes, the difference is there, and I think it has helped prevent frequent hospital admissions.
Having one point of contact will be much easier for me. I'm really, really happy with this, and Dad seems to be getting better, and my life seems to be improving.
The value of the social care with the MDT meeting is because it's able to discuss and to work as a team. It's very beneficial for the patient, because if it's only one team that is visiting, seeing the patient, you'll not be able to really overall holistic assessment for the patient.
My role acts as that link between the team, the MDT team, and the patient. So essentially it's about making sure that decisions are coordinated and managed and focused on the patient, but also making sure that whatever decisions or actions that have been agreed are fed back to the patients and the carers.
Being able to learn from one another, so that's another thing that I think is really great. Using each other's resources and professional input.
Firstly, it has reduced the number of calls we have from the patients or their carers, because once the team has been set in motion, they do know where to call, specifically instead of everything going to the GP as it used to be.
The MDT, I believe, also gives an opportunity to understand the dynamics of each individual roles, their constraints, their limitations. So you don't get frustrated when, for instance, I'm expecting social services to do something and it's not happening, because there's a better understanding of what they can, what they cannot do, and that kind of reduces conflict. Patients get that sense of everybody is talking. everybody's together, everybody's agreed. There's a consent, there's a plan as to how I'm going to be looked after. And I feel for patients that's reassuring, just knowing that it's all coordinated and it's coordinated around them.
I think it's important because when we're looking at patients, it's not just about their medical needs, it is about their holistic needs. So there's a lot of social, psychological, as well as their clinical needs, and it all has to be considered together. You can't separate those things.
Okay, what I like about that video is the fact that it is that holistic care that you provide, working as a team. There's that one point of contact. So for us, you know, it's coming to the GP, and if anyone's not sure, that, you know, everyone is included, whether it's emails or through the case conferencing team meetings or what have you, that we can share, okay, who's doing what, know what's, you know, is being followed up, and it's that transparency as well, so things aren't being missed. And we know that even just one small thing that's missed, particularly in supporting this population with their health, can actually have really quite drastic long-term outcomes as well. So, and I like also the fact you learn from each other. You learn about what skill set other people have. So you're not trying to reinvent the wheel as well. So it's that efficiency that case conferencing, working as a multidisciplinary team also provides as well, and what people's skills and strengths are too, and what they bring to that holistic care that we provide the patient, and those shared goals as well in meeting their health needs. And the person too is also always a part of that process, that person-centered care, in working with them. So moving on, so you've got all your information collected from the comprehensive health assessment. You've gone through everything, you've identified health needs, you've looked at what's maybe changed, what investigations are required, if they need any certain pathology testing or screening or what have you, then you look at that, okay, you've identified what the health needs are, or what changes have happened from the last over the last 12 months. So your tool that you use next from that is your chronic disease GP management plan and your team care arrangements. So this is where, and even though, as you're probably aware, your requirement is that to be able to facilitate a care plan, that the person has to have at least one a chronic health condition that's been present for at least 6 months longer. And we know that many people that we support do have many or multiple chronic health conditions. So it's available, 721 is the item, and from that we'll then highlight what all the needs are, and do a health action plan at the end of the comprehensive health assessment. Now, I keep saying that we actually don't use the CHAP in the practice that I work at. We use another assessment, but it pretty much covers the same thing. It's just a different performer, and it sits within our medical records, so that we can pull it from that. Which I understand the CHAP is actually, they're going to be integrating it into, I think it's best practice software, medical software. So just keep an eye on that. I haven't heard any more. We don't actually use best practice where I work, but that I know is definitely something that they're looking at integrating within medical record software. So from that, you then identify, okay, in the care plan, who are going to be the service providers? Who are the current service providers? Now, what we do when we actually do our health assessment, we also do ask who the person's current providers are. Are they still involved, or is there someone new? So we'll go through all their allied health, dental, medical specialists, their NDI support coordinator if they have one, significant people in the person's life that support them in a paid role, in a non-paid role, finding out who's there. So from that mix of people that we've got, we then highlight, okay, who's going to be a provider within the person's care plan. And generally it is medical specialists, allied health. It can be anyone that is supporting the person, just not family member or paid carers. So we then highlight who they are, make necessarily referrals. depending if they're new or existing, we will then invite them to be a part of the team care arrangement to support their health needs. Not everyone is part of the team care arrangement. So for instance, one big one would probably be, say for instance, podiatry. And often they will need more podiatry. So we will work very closely with the NDI support coordinator and with the person's whether it's their family carer or their disability support worker or their residential house supervisor if they work in an supported disability accommodation, and with the person themselves if where they're able to contribute. About whether their needs, because of their disability related health needs may be better addressed through the NDIS. So often people get their podiatry managed through their NDIS rather than those 5 Medicare rebated items, because that may not be enough to support their foot health depending on what their needs are. So that's something that we look at. Dietitians, another one that we might be better supported through the NDIS because their dietetic needs are associated with their disability, and so it's going to be better managed. Diabetes, those sorts of things, like diabetes education and what have you, would be managed through the NDIS. And that's where, as I mentioned before, it's really important to consider the NDIS and what the plan the person has. We always, wherever possible, have the NDI support coordinator come along to the case conferencing meetings, because they have a lot of information that can provide in terms of the services and supports that the person's receiving. So like whether it's their residential support or their day service, or whether they've got, requiring a functional assessment, say for instance, because they're moving into a different accommodation service, because those things help inform, okay, do we need to make a referral out to OT? Do they need any medical justification to help support that referral for NDIS funding for that particular need? So that's something, and I'm going to be working with Kerry and Nicole to look at some templates in terms of how you can actually, in your role, you're an advocate for the person, even though you're their health advocate in a way. It's the goal of the NDIS is for someone, for the person to live the best life that they can. And so, we're here to support them in that. And their health is, a really important part of that. So help, supporting them to meet those health needs with their NDIS plan. Yeah, it's key. So again, you sit down, and this is where you bring together people and say, okay, we're looking at, putting together, a team care arrangement. Would you like to be involved in this? If not, you may be involved because you're an NDIS provider for that person's health needs. There's also the practice nurse provides support and monitoring between visits with the GP, and that's 5 visits a year that can be claimed under that item number as well. And depending on the person, we will actually do a care plan review. Sometimes it might be every 6 months. It could be every 3 months. It just depends on the person and their needs and how frequently they change, or how frequently they may have health providers getting involved in their health care. So that's something that we can keep an eye on. With health assessments, I'm not sure if you're aware, but to be able to claim them, it has to be 365 days plus 1 day for you to be able to access. So it's really important that if there's any practice nurses here to always be checking PROTA to make sure that they're eligible for that item can be claimed, and same with the care plan. It's not as strict when you're doing a care plan review because someone says, as you know, it can change very quickly, so you might need to bring the review forward a little bit, but in terms of the claiming for the health assessment, Medicare are very, very strict with that. Okay. So you can actually get this QR code. You can actually get easy read information about care plans and fact sheets about people's health from CID, so the Council of Intellectual Disability. They're based out of Sydney, and they've got some great accessible information that people can, help them, empower them in managing their health healthcare, but also that you can, provide this information to their carers as well, because many carers or paid carers are not actually health trained. So that can also help them understand, what the processes are, or what care plans are, and how it's going to promote the person's health needs. So again, these are just the requirements for Medicare for it to be accessed. So it's just what you need to have in your notes and what have you. Team care arrangements, as I said, highlighting the needs and who would be best to be involved in that person's team care arrangement. And then, so I do a lot of this. We'll work with the providers and invite them to be part of the process. And pretty much, talk about what their treatment service goals are. And we do a lot of that. Once they're on board, we talk particularly around those sorts of things within each time we meet in the case conferencing. So the family or informal carers can certainly be part of the process, but they're not actually one of the minimum 3 providers. And just to be aware that, patients may be eligible for the Medicare rebates. So that's the 5 visits a year. Sometimes we might have 5 podiatry, might have 2 dietetics and 3 psychology or what have you. It just really depends on what the person needs. And then that's also got to be retained for 2 years in the patient's records. So why case conferencing? Okay, so I've talked about the process of getting to case conferencing, getting people on board, you're finding out what the health needs are. And really, you're all working together as a common purpose, and it's providing that continuity of care. You're breaking down those silos. Everyone knows what everyone's doing. You're aware of what other people's roles are and what they do in their profession. And I think that's really key. Just hearing what, an endocrinologist is doing to support the person's diabetes. If you're an OT, you may not have known of that. And then you can share information that you may not have thought that was relevant to raise. So I find it's that stuff you can't capture that in writing. It's something that comes up in conversation. It's very fluid. And someone might say, I picked this up when I went out and saw John the other day in at his service, and someone said, actually, yes, he's been doing this in this environment. And then someone else might say, I've noticed that. So you then come together and think, okay, we're forming a bit of, great collateral information that, it really enriches the information, so that the GP and those involved in certain areas of the person's health can really help guide in meeting the person's goals. As I said at the very beginning of tonight, it's preventative rather than reactive care. And, anything that the gaps in knowledge, as I've also mentioned before, or any logistical barriers, you can work together. One example that we takes a massive team approach is here in Melbourne, in my other job in disability at Monash Health. We have a program, it's the Disability Health Access Service, and it's where people can access health screening, health assessments under sedation. And the highest level is under general anaesthetic. And, it's a team approach in terms of we use Ambulance Victoria to help transport the person there. We then use Monash Health and the nursing services, disability services there to get the person in. But then you might have the endocrinologist might say, I need bloods for this, or the GP might say, we haven't checked the person's vitamin D for a long time, or we check Rota, the nurses check, they're due for their immunizations, we need to have a hearing check, or we need to have ears cleaned or podiatry done. Dental will come in, and it's like working together as a team, lead planning that process with the support of the disability support service at Monash. It's a team approach. Otherwise, these are people that otherwise you would never be able to get close to be able to examine them. Because of this, we've been able to pick up on so many things and direct their health care to manage those health needs, and it's that real preventative health care. Okay, so how do you get started? So you need to be able to gain consent for there to be case conferences occurring. If the person doesn't have the capacity to consent, it needs to be the whoever the next of kin is, or if the person has a nominated medical treatment decision maker. Yeah, and some people don't have that, so therefore you may have to go to the Office of the Public Advocate to have guardianship put in place to look at for certain, you know, discussions or what have you, and talking about how, you know, having these is going to help keep the person well and disease-free or minimise that. So that's really important. That has to be on the person's medical records. It's just a signed statement to say that you agree to case conferencing to occur. And every time you do have a case conference, that just has to be mentioned in the notes that there is consent has been obtained. If the person's able to consent themselves and they understand why health professionals and others are coming together to talk about their health needs, then they certainly, if they have that capacity to do so, then they can certainly consent. We do have a few patients that have signed consent for case conferences to occur. So the coordinator is managed by the GP, which is Medicare requirement, but pretty much the coordination sits with the practice nurse. So I do a lot of coordinating case conferences in my job. We would have anywhere from 2 to 6 to 7 a day. It just really depends on the patient. Meeting considerations. So do you meet face-to-face? If you're not going to meet face-to-face, you have to, and you're going to be meeting online, it has to have an audio-visual component to it. So that's something you need to consider. So there's a lot of telehealth platforms out there that you can access. Health Direct actually provides a free telehealth platform. We don't use that just because it can only be used by one person at a time. It can't be, you can't have 2 people in using the system at once unless that's changed. So as you can appreciate, we're always using having online case conferences, so that's something that we have another platform that we use. If you've got elderly carers or the person themselves coming in, do they have access to a computer or a laptop or an iPad or even a phone where they're able to dial in? So those sorts of things, are they able to use technology? So sometimes you might have the parents might go to the NDI support coordinator's office, or they might actually come into the GP practice and sit in person while everyone else is online. I have to say that with all the negativity that happened with the pandemic, one of the silver linings was people having telehealth basically. And I think, you know, gone are the days where we would have this doctor's room and we'd all squish in there and, you know, have a case conference. So we didn't have many of them because of that, and trying to coordinate, you know, people driving from the other side of Melbourne or coming from hospitals or what have you, or fitting in with day programs and whatnot. So being online, people can like, yep, I've got the time, I can just jump on, do it in my, we have people sitting in their car, all sorts of places, out in the park, at the back of the house, you know. Yeah, so it's a lot more flexible in that regard to be able to be online. So dissemination of the conference outcomes. So that's where you can provide easy read for the person or however they best understand the information. And I think there needs to be more work done in this area. In saying that, most of the time we don't have the patient present at the case conference just because of the population that we support would have struggled with the difficulty of having that capacity of understanding what's being discussed, but we still encourage their disability support worker or their carer or their family member to actually talk about what we're doing to make sure, you know, to keep them healthy and what's happening, and providing them with resources so that they can talk about, okay, this person does need to have a DEXA scan, or this person does need to have, you know, a breast screen or what have you, and providing them with the information or pointing them in the right direction of where they can find social stories or information where they can sit down with the person to explain, doctor said this, and nurse Heather, she said that, you know, this is, you know, we can read through these, this information that's going to help you keep your breasts healthy. For example. So we generally have an agenda. So sometimes it might be sent out by the NDI support coordinator or a nominated person that sort of likes to just coordinate that. And then we'll have a copy of that, and then we'll actually meet with the and sort of have that discussion. Generally, the GP will have a list of things that they want to discuss, like pathology outcomes or recent you know, appointments, what's happening, or they've highlighted another need, so they want to bring in the dietitian and say, look, we've noticed these changes. Or diabetes is one that often will have the person come along, the whether it's the credentialed diabetes educator or the endocrinologist, because it might be new information that they're not aware of or have been sent. So they can then hear how that's going to impact. And having, you know, the dietitian there, they can then say, yep, great, that'd be great if you could take on that role, or managing that particular spike in what's happening with the person's blood sugars and what have you. So for us, as you probably appreciate in GP land, and particularly if you're in a very busy GP practice, primary health practice, that, you know, we generally book an hour to an hour and a half, sometimes 2 hours. It really depends on the person. So we actually book them pretty much for the year, or at least 6 months in advance. Sometimes the person we might only do a case conference every 3 months. It could be every month. It just really depends on their needs and how many people are part of that multidisciplinary team, the team care arrangement, and others that are, you know, that come along to the case conference. And so we'll schedule those in, just because we know that's, you know, on the 4th Thursday of every month, we will meet at 11 o'clock to discuss this particular person. And because you've got that regularity, people know, and people are less likely to say, look, can't make it, or it's clashing, because they've got it already booked in. And that's something that I do in my role in booking that forward. But that might be something that your practice manager or your reception staff can do. There's also document requirements. So these are just, I've been doing lots of talking, but you can have a look at these. These are all from the MBIS online. So you have to have the date, the start and the finish time of the case conference, the participants, so those who attended, and also those who were invited to come along, who regularly come along, but they're an apology. The history, so we just pull that that's generated from the patient's medical notes that goes in. So it's like their diagnoses and health needs that have been diagnosed, what the current problems is, again, that's just automatically populated from the person's notes. And hopefully once they get the CHAP integrated within all best practices, I'm aware that'll make life a lot easier for you. Again, as I said before, that statement of agreement for consent for discussion to have case conference, and statement that it's actually on the patient's file, and the actions from the last case conference. So basically we just we'll highlight those and pop them in the start, or the GP will do that in her medical record. So then we'll go through what needs to be achieved, who's going to be doing what, service has been delivered, what was presented, what was talked about, what the outcomes were, what the you know, who's following up what. And then it's a copy of the case conference notes are offered to the participants, and those and then sent out, which is what we do. We email those out. Sometimes the doctor might say, look, I'd like a copy of that to go to such and such, just because they weren't necessarily needed to be in attendance that particular day, but something's come up. So we'll send it to them as well. The doctors, in terms of who take the notes, the doctor does, and it's their medical notes that they take, and they order it in a way that's then we just download those and then send them out for all the attendees. So that's what you require. Working in this population, because it's a vulnerable population and you're spending a lot more time generally with someone, and with case conferencing as well, that's a lot more time. So you're probably going to be more, I don't know, Medicare. I don't know how I can put this. It's where, you know, you're more likely to be picked up because you're not doing your 6-minute consults or your 10-minute consults or your 15-minute consults. You know, it's 20 minutes and 40 minutes and 40 minutes plus. So it's really important that, you know, that you have all this information. If you have it there, that's all that they were requiring from you. So yeah, I've just mentioned that. Just need to make sure, again, this is all taken from MBS, and I know Kerry has put together and Nicola put together a great documents that links to these on the MBS online. So really this is just the role, just to highlight here, the GP. So you're identifying those needs, which you've already done through the comprehensive health assessment, and the goals, and bringing the providers in through the care plan. You know, the person's capacity, and, you know, the consent has been provided. Referrals, you know, the reminders, recalls, those sorts of things. The action discusses the outcomes, how we're going to deliver this support, and, you know, making those reasonable adjustments. So that's pretty much, you know, plus everything else that GPs do. So practice nurse. So in my role, I do, you know, the appointment preparations, collaborate very closely with the GP and with the team. So it's communicating with them. We do it via email. We then look in the reminders and recalls as well, support the GP with that. A lot of my role is patient advocacy. So, you know, it's you know, because I'm very passionate about working with vulnerable people. I also probably should have said my youngest has Down syndrome. So I also have that lived experience of disability, and seeing, you know, a child that's gone through a lot of medical trauma. So you become a very strong advocate for people having that lived experience as well. And so often, you know, even though you're working with a minority, they actually have some really major health needs and health supports and social supports and mental health supports. So I think, you know, the nurse is really well placed to be able to advocate the need for, you need to come to this meeting, or you need to make sure that there are reasonable adjustments are made in the clinic environment. So whether it's popping out the back and having the case conference in the car, that's absolutely okay, or clearing, you know, the front waiting room and only you know, doing it on a Saturday morning, or, you know, when clinic closes at 5 o'clock in the afternoon, so they can come in and there's not that busyness and noise and everything that's going on. You know, we've got a fish tank at work, and it's great, people come in and it's just focus, you know, before they then come into the room to see us. If you have to have the lights off when you're doing a health assessment, or you could sort of see, that's absolutely okay. And it's, so the nurse, you know, we provide a lot of that advocacy and those reasonable adjustments with that. And also I do a lot of provision of health resources and information, or at least signposting people to resources that are out there. And there is quite a lot of stuff that is available. It's just a matter of finding it and knowing, you know, knowing where to go. Administration, so just the booking appointments. So this is your reception, your practice manager, whoever manages the administration within your practice. You know, the reminders, ringing up people, because you don't want to book in a comprehensive health assessment, a 707, and then the person doesn't turn up. So it's really, you know, they will ring the day before and just remind them to bring a urine sample and what have you. So they're part of the team as well. And they also make those reasonable adjustments. They can see someone come in and they're a little bit tense or upset. Yeah, let's just come up to the nurse's room, or let's just come out to the kitchen, or, you know, let's just, you know, can I get you a glass of water? You know, those sorts of things. Because we're trying to make those positive experiences for people, you know, so that they're more likely to be more comfortable to come in and see us, so that we can talk about their health. So it's as I said, it's a team approach. So just to summarize, making sure you got your consent, the support that's needed for the person, you know, preparing them for the appointment. If they are having a health assessment, who's going to talk to them about, you know, what's going to happen for them. If they have them every year, they come in and they're going to see Nurse Heather. Yep, that's great. You know, look forward to it. They bring in a toy, they bring in a book, they bring in a magazine. You know, I spend those first few minutes talking about what you would have been up to. And I think it's that discussion that you have with people, that general chit chat, that you actually do get a lot of information. So I think that's really important. Don't think that I've got to rush the person out the door. So making that time. So as I said, we have an hour and a half of the care plan and the health assessment. You know, it really is key. Really great if your practice can develop a reasonable adjustments plan. So, you know, what's it going to, you know, how can we bring someone in? I had someone a few weeks ago that I did a health assessment on, and his carer brought in these little bags of, I don't know, they like cheesels. And, you know, we know for a fact that he will only sit for 10 minutes and then he's out the door. So there's another carer supporting them. They'll go for a coffee or something down the street. But the carer said, look, we're going to see if we can get him to stay a little bit longer. So he brought in a packet of all these little cheesel things, and he kept eating these cheesel things, which is not a good look, you know, doctor's surgery, and you're asking them how, you know, what's your diet like, and, you know, what do you like to eat? And he's eating these cheesels. But you know what? He actually stayed for half an hour. And it's like these little wins. And he was happy for the GP to come in, and he actually, you know, let her listen, or just at least put the stethoscope on his chest. She didn't hear much, but it was just enough that, you know, he was relaxed, he was having his cheesels, he was happy. you know, he didn't mind her coming in, whereas normally she couldn't get near him. So it's just those little things, you know, that you need to consider. So reviewing the outcomes with the person as much as possible, and then how you're going to translate that information so that their carers, their support workers, their disability support workers, can follow that and implement the care as required. And just also identify the need for how often are we going to have case conferences for this person to keep them well and keep them healthy. And just your documentation, really important, really important to keep that on top of that. So this is my little map. I'm happy, probably, Robert, if anyone has any questions around case studies or a patient that they've got currently in their service, how this might fit in. But I think it's, or I'm happy to go through a case study of someone that came in new to our service. It's just whatever you can see on the chat and the Q&A coming through, Robert.
I can't, there's nothing on the Q&A at the moment. Right. So maybe if we go through the case study, because I've certainly got some questions I'd like to see how you can help my practice with this in a practical sense. That'd be great.
No worries. Okay, so we had a 20-year-old woman. Now this is pre-pandemic. She came in with a mild intellectual disability, and she basically she lived with her parents. In summary, she had a part-time job, but she was supported within that job, and it was in retail. She came to us. We did a comprehensive health assessment. What was happening? She was managed as a child in her family GP practice for many years, and then the GP retired. And the other GPs that were in the clinic, there's a lot of movement with people coming in, people leaving, and they felt that they didn't feel comfortable, or this was reported to us by her and her mum, that they didn't feel comfortable in supporting her health needs and thought that she needs specialist disability support. So she came to, they found us. So she had, from the health assessment, we found that she had type 1 diabetes, and also just that sitting down, getting to know her first. We just didn't do the health assessment on the very first visit. It was, getting to know her and what she wanted to do with her health, and what were her goals in life. She wasn't an NDIS participant, but she wanted to live independently. Her mum was a little bit concerned because she also had type 1 diabetes. Sort of okay managed, but she was very hesitant about the fact that, because she lived at home, she was able to sort of keep an eye on her dietary intake and the management of her diabetes. She had shoe orthotics, which she'd outgrown. She was having a lot of issues with her knees, which was impacting on her work, because she was standing for many hours in retail. That was meaning that she wasn't able to last as long in her job, long shifts. She was moderately overweight, and also there was unknown etiology. So she also was really well supported in paediatric services, but we know that they're those sort of alarm raising areas, those transition points, so from peds into adult services. If they've been well supported in paediatrics, sometimes that can fall through the gaps a little bit in adult services because they don't know who to refer to, or there isn't something more specialised. Or it could be that the paediatrics have managed all their health needs, not in this case, but we do find people their health need was managed all through the paediatrician and not through the general practitioner. So it's really important, if you are supporting children, that keep building that relationship. And again, case conferencing can really help inform that if the child has complex health needs. We only see a handful of kids. The majority of the patients we have are adults. So I probably should have mentioned that before. So okay, so what were the outcomes? So we did a comprehensive health assessment. So we had our initial appointment. And then comprehensive health assessment, these were some of the needs that were identified. So the fact her community access was being impacted on her knees and also her feet because of poorly fitting orthotics. Her diabetes management, it was okay, but it could be better. and because she wanted to move to independent living as well. So we did the usual health screens, or investigated, okay, what screens had she had. Issues with the feet and knees, particularly when at work, as I mentioned. She had a BMI of 27, so she was moderately overweight. And as I said again before, we didn't know her etiology. So we actually supported her family and her to apply for an NDIS package, because we felt that her health needs were impacting on her ability to, and because of her disability, that you were impacting on her living that life that she wanted to live, that best life possible. So there is, and I think I've got it in a later slide, there is it's a pretty onerous process. I do a few of them. Applications, but you can do them online. You can encourage, get the person to be supported to ring on the phone. They can be done in person, the actual application. There is a 2 or 3 page pamphlet for general practitioners, guide to the NDIS. So I really encourage you to have that accessible, with your colleagues and what have you. We write a lot of letters, supporting letters, looking at a person's health needs and how their disability is impacting on their health. And so we'll write a lot of health needs referrals to the NDIA, stating the need for dietetic support or podiatry or respiratory health or physiotherapy. It really depends. And we rarely get knocked back, I have to say, because we can justify, we're advocating why that if this person doesn't receive these services, then they're going to be in more advanced stages of disease, and they're more likely to have repeat visits to hospital. They're more likely to be coming back to their primary care. It impacts on their ability to access the community or their day program or their place of employment. And we always say, I know it's very negative, but it's what's the worst day look like for that person, and then base it on that. Because it then highlights that, we don't know if they're going to have 4 bad days every week or 3 great days. So it's better for them to, to write that application or to state what their needs are on the worst day that they have, what that looks like. So that's just a bit of a tip. So identified health providers. So from the health assessment, we knew they needed a new GP because she lived on the other side of town. So it wasn't practical for her to be coming across to us, and she wanted to go somewhere local. So we approached, had a look and supported her in finding, and her family finding, a new GP. We identified the need for endocrinology support with her diabetes management, and looking at, okay, she's looking at moving out of home. Can she have, what's her glucose management? Can we put her on something where she's can have a Libre or something where she can manage her own diabetes and have it on her phone and look at what, that continually glucose monitoring. So how would that best be placed? And then looked at, okay, maybe we need to get a diabetes educator involved to help her, to teach her, okay, so how are you going to manage this? So we looked at that. That was something that was quite, a priority for her. An orthotist, so that she wasn't in pain when she was standing on, all hours. Obviously her orthotics weren't meeting her gross motor needs, and also her foot health. So we need to look at, okay, that's something we need to investigate. Weight management, okay, we looked at exercise physiology, which was certainly, that was something that we referred out in a team care arrangement, because she just needs someone on board to get her started, to get a program going. And also the dietitian, which would work quite closely with her diabetes management too. And also how we could develop a healthy eating program. And that's where we also identified the need for OT support. So, to do a functional assessment, how, what were her activities of daily living like in the home, what supports would she need? And that also helped formed, again, the justification for her need to have that NDIS support for that. We also genetic testing, just because nothing had been done in the past, and she just had certain features, morphic features, that we thought, we would look at that, but it came back that she didn't actually have her microarray was negative. So the care plan providers, talking with her and her mum, that definitely podiatry. She wanted to involve the orthotist, so looking at the specialist shoes, the endocrinologist, and the new GP, dietitian, podiatry, just for general podiatry needs, and also because she had diabetes, and exercise physiology. And then the team care arrangements, it was identified, okay, which of those, that we would look at in particular with the part of the team care arrangement, and what was going to be more around the MDIS funded ongoing down the track. So, so you can see that there. Okay, if I skip something, no. So basically, she's no longer part of our clinic because we're able to, she was successful in gaining an NDIS package to manage all her health needs. And also her social needs, and that goal that I want to live independently and be in control and my own captain when it comes to managing my health. So which is really lovely. So I think just sort of finishing up now, really, as you're probably aware, the primary health care, actually I might have skipped one. There is the lovely Kerry and Nicole have actually put together case conferencing items. It might be a little bit later on. And so you can actually see what we use in terms of claiming. But, really it's around embracing that inclusive practice that I've been talking about, delivering that multidisciplinary team approach and care and that integrated system, and being able to, meet that patient at those particular touch points in their care. There you go. I was ahead of myself. So these are the items, and I'm sure, Kerry will send those through, and they're actually live. So the ones that we will do mainly would be the 743 for all our case conferences. That's pretty much the one that we would be claiming most, because as you can appreciate, when someone's got complex health needs, there's a lot of discussion that is had. I like this little diagram, or this little table here. Dr. Aileen Smith, who is a GP in Sydney, who provides, also works with a lot of patients with intellectual disability. She just put together this little summary of the items that she regularly or frequently will claim in her role in supporting this population, her patient population. So obviously the care plans, reviewed care plans, case conferences as well. Mental health care plans. I haven't talked really anything about mental health tonight. There is a component within the CHAP around mental health. We also have, many of our patients have behaviour support practitioners who are funded through the NDIS, and they're a really key part of your case conferencing team as well, because they can help inform and look at managing behaviour. As we know, it's a form of communication. But is that behaviour because the person has an undiagnosed mental health need as well? So that's a really quite important service if the person does have behavioural needs and or mental health needs. The other thing, we often, one of the questions in our, I'm not sure if it's in the CHAP, but is, has the person had a home medicine review? We pretty much all our patients will have one, just because they're on so many medications, all different types, from your vitamin D to calcium to anticonvulsants or antidepressants or multivitamin, it all adds up very, very quickly. So that's a really great resource, and we work quite closely with a clinical pharmacist that supports us around medication and keeping that polypharmacy, limited for the person. So it's very similar for us. So I've mentioned before about the practice-ness item that you can claim. Now, these are the resources. I'm sure Kerry and Nicole are putting together a bit of a pro forma in terms of each of these. I really recommend you, if you're working with someone that's got a particular disability or a particular diagnosis, contacting the peak body for information. So for Down syndrome, Down Syndrome Australia or Down Syndrome Victoria, they're a wealth of information when it comes to, you know, Down syndrome, and they have some amazing health resources. They actually have a from birth to adult to end of life screening tool, and it lists all the different stages that you need to be, you know, checking for, you know, in infancy and at this age and school age, and sort of tests or things that you might want to be using to investigate any potential health needs like hypothyroidism and things like that. The My Lived ID is an amazing resource. It's for health professionals, people with intellectual disability, and carers and family. And you can actually highlight here what you are, and then it'll come up. And this is around mental health, but we know that for someone to have great mental health, that they also need to have great physical health and, you know, great well-being as well. So I was involved in the development of this website, and it has some really great resources on it for supporting people in their mental health. It also provides support for Aboriginal, Torres Strait Islander, LGBTQI populations, and CALD as well, for people with intellectual disability. There are a lot of resources out there. I've got a few here that I could show, but they'll get lost in the blurred background. But yeah, you can jump online. There's so many apps out there that are great. But the key is when working with someone, what do they use? How do they like their information provided? How do they communicate best? How do they like things presented to them? It could be something as just a simple outline of a body, and then you're pointing on it saying, show me where it hurts if they don't like to be touched. Or it could be they like easy read, or they might have a formal communication system that they use. Get them to point to pictures, those sorts of things. You know, find out how they communicate, and you take on board that system. For practice managers and reception, you can actually get templates where you can actually type in about, this is when your next appointment is, this is what you need to bring along, and what have you. There's health fact sheets. Don't underestimate, if you're trying to talk about, like COVID was a really big one, getting people to have their COVID vaccine, using resources that have peers. So particularly in the Down syndrome community, people seeing their peers talk about having the jab and how it stops you from getting sick. Really powerful stuff. This is the Council of Intellectual Disability that I was talking about, the NDIS for GPs. There are quite a few health passports out there, but really, you know, they're great, they're comprehensive, they're wonderful, but, you know, I get a little bit worried that they just sit in a filing cabinet sometimes. They need to be kept alive. So just having my top 5 is what makes me happy, how I best communicate, what I don't like, what reasonable adjustments you can make. There's a varying things of, you know, and having that there. And then that means if it's on the person's file, they can bring it along. Everyone can say, okay, right, this person does not like having beeping noises or something like that. So you get to learn the person more. So there are lots of resources out there. It's just, as I said, finding them. For anyone here is a nurse, really encourage you to do the Every Nurse's Business, CPD. It's actually free. There's 3 levels, and you learn about how you can support people with intellectual disability and autism spectrum. And it's just building that capacity of working in this population. Dr. Robert also has mentioned this, that is available in the health pathways. And yeah, on behalf of Kerry and Nicole and Robert, thank you so much for coming here tonight. And I've hoped you've learnt something. Yeah, and I'm more than happy to provide any follow-up because what I've talked about tonight is what works in the GP practice I work in. I also probably should have said that the GP I work with, she actually specialises, and the majority, pretty much all her patients have intellectual disability or complex physical disability. So yeah, but no, any questions? I'm here to help.
Thanks, Heather. That was just an amazing presentation. I think there's so much information out there and so much good work done by people like yourself. It's just quite incredible. I always find, you know, the more I learn, the more I realise I don't know. Because I wonder if it can be a bit overwhelming sometimes for GPs in busy general practices.
Yes.
So one of my questions is, when, you know, and we talk about case conferencing, how do you organise it? Because I run late all the time. I could never organise a video call with 3 other people to occur bang on 3 o'clock.
That's just it, because I have to say, pre-pandemic, because we just didn't use online telehealth, it was face-to-face or phone, and because the requirements changed with the pandemic as well with telehealth, we were always running late. And as you can appreciate, with this population, they'll often come in with one thing and then there's something else and there's something else. So it just made us, the GP that I work with work smarter, just because you could have 10 people in that case conference, or you could have 2. The other thing that I didn't mention too is our case conferences are not just about the person. We also do case conferences with medical professionals. So we actually have regular case conferences with a psychiatrist that works in intellectual disability. We also have case conferences with an endocrinologist who has a special interest in intellectual disability. And so the GP that I work with might find, all these interesting results from pathology, thinking, and so what she'll do is she'll actually then discuss that person's particular current health need, and that endocrinologist or the psychiatrist will then provide their expertise in terms of, okay, this is something you need to be looking out for and highlighting things for her to be aware of. And so we use it in that format as well. We also, many of our patients live in residential services, and there's quite a few houses that we support pretty much all the residents in that house. So we'll have a monthly or a bi-monthly case conference with the house supervisor, just to touch base, to see how the person's going with all their health needs. So it may only just be with the health supervisor, or they might say, look, I really want the behaviour support practitioner to come in, or I just want the dietitian to come, because they've just found something recently. So that's another way in which we use this on the case conferencing. But I think, going back to your question, you do run over time, but I suppose we are really careful with how we book case conferences so that we don't have them one after another as well. So, if they do run over, then, if we might have a face-to-face person that might be waiting a little bit longer. Yeah. So, or do it in the morning or do it later in the afternoon. We do all our health assessments on a Saturday morning. Just because they always run over.
And so GPs can get remunerated through Medicare through those item numbers you said, which, look, and I've never used a case conference. I'll freely admit it. They're also a bit complicated. I might explore that now. How do other specialists get paid? Do they?
So they can claim.
But if you want to be, you want the psychiatrist,
so they can claim as well. I'm not up with the billings in terms of the medical professionals. My role is actually we send, and my colleague, there's another nurse that I work with, we actually send the case conference times to the medical specialist's receptionist or their practice manager, or to the person themselves, and then they manage that from their end.
And would your GP have a sort of a cohort of specialists they normally use and are familiar with?
It's sometimes just when we do highlight the need for, say, for instance, dietary support, when you get hold of a really great dietitian or you get hold of a really great podiatrist, you tend to ring them up and say, right, I've got someone else for you, and we try not to burn people out too much, but you just find people that are really passionate in supporting people with intellectual disability, probably because they've got a lived experience, or they're just really passionate about this population and wanting to support their health needs. So we do often, we don't just willy-nilly refer out to anyone. Often I'll investigate.
And certainly through the Spider project, we've learned the chat tool is a lot more available now, which has been fantastic.
And it's free. I think the good thing about the chat is that because it's split into 2 sections, so the first part is emailed out to whoever is going to be bringing the person. They've got to fill that in, so they've got to go to their records. So a lot of that's done at home, so it's not busy asking those questions when the person comes in. They then send it back within a week or 2 weeks, whatever nominated time. It just really depends. And when we were actually using the chat platform, or the previous one, we would then go through and think, this needs to be looked at. This needs to be looked at. So the nurses would go through and say, say to the GP, this is something we've flagged this, you might need to ask more questions. And then when they come in, we're sort of prepared with that information, plus, the previous health assessment, which we also review to look at, if there's any changes, and then look and then do the complete the health assessment. Yeah.
And I like your comment about the little wins throughout the process. And I think part of the CHAP tool is to do it. If you do it on a regular thing, those little wins can become cumulative over time.
Yep.
And
Sure.
even if you just get a little win now, it can build on for next time. But if you don't do them on a regular basis and have that sort of as a routine.
Yeah.
How often would you generally do case conferencing for a patient? Is it once every 3 months, or
some
are you
patients
scheduling them more frequently?
Yeah, we don't do it with every single patient, just because they're able to manage their own health needs really well. So we'll just see them once a year, or if something changes where they have a new provider, so to bring that person into, and they want them to be part of their care plan. Or when we always do a care plan review, generally every 6 months, or 6 months after, just to touch base, because I think it's that we've found that the more frequently you do that, you're less likely to have people presenting or ring up saying, I need you to come in and see me, I need to come. And what we also do is that sometimes if someone comes in and we're not able to see them because we are very, very booked, we've also we have a lot of registrars that come and work in our practice. And we're also, I suppose, on the quiet, sort of educating them about people with disabilities. And they might come in just to, if they've got a sore foot or they've cut themselves or what have you. We'll certainly see people in that regard as well. But I think, it's also that capacity building of your peers. We have general practice nurses that don't work with people with disabilities. And so we might say, oh, look, let's go see Jess. Jess is going to do your blood pressure today, or Jess is going to come in and do your COVID vaccination. Again, making it so that you're setting the person up so that if you're not able to support them when they need that help, that there's that contingency there for you. In terms of how often you would provide a case conference, we've got some people where we would do, most people living in residential care will do monthly, and that's generally with a house supervisor. Where it's the your team care arrangement, or a greater care team, that could be anything from once a month, once every 6 weeks, once every 2. It really depends. The more complex the person, the more frequently we'll probably do it. Yep. And sometimes we'll do case conferences that's just with their residential health supervisor, and then we might have a massive care team meeting once every 6 months. So it just really depends. And that's just organically developed, particularly again because of the pandemic, that we're able to, and we've just found it so successful. And now that GPs are really have that ability to claim, because I think it's important that it is a lot of work, and I think you need to be remunerated for that. And then there is a lot of advocacy still going on, that you need to be better equipped to support people so that they're not becoming sick and
it does sound like something as a practice you need to plan a little bit.
Yes.
As a practice, and as a GP with a special, almost needed a special interest. And you mentioned before with your case study the lady that transitioned when her GP retired, and the rest of the practice thought they weren't able to handle her needs. And it was almost like a negative, but in some ways it can be a genuine observation. We're not going to do a good job, and that's and probably the outcome is better for her because she gets to see someone who does a good job.
I think, and we certainly don't see that, because we totally understand how great a job it can be for working with people with complex needs, and acknowledge the fact that many practices are very busy, have a lot of patients, and they just don't either have the environment to provide that support, or the knowledge as well. So I do, as you mentioned at the beginning of the introduction, I do quite a bit of medical undergraduate teaching, one of the universities here in Melbourne, with their 4th years in the primary healthcare of disability, and also the mental health needs of people with intellectual disability. And it's really interesting working with the students, saying that, look, it's about inclusive care. So even though we're talking about a particular population, this can apply in many populations that you're supporting, if you do move into primary care or general practice, or any patient really that you're supporting. So I think, and that's really moving forward now with the Centre of Excellence in Intellectual Disability Health that's just been launched this year, around in being able to better equip health professionals across the board, and medical undergraduates, nursing undergraduates, allied health. Yeah, because often it's just, I don't know, I don't have the ability or the I don't have the skills to support someone. Yeah.
Yeah. All right. Thank you so much, Heather. We are coming to the end of our time. I noticed Nicole's put a couple of things in the chat, a couple of PDFs there from the Spider project. And we are getting to the end, and probably the end of the sessions for this year. So I'd like to thank everyone for attending. I'd like to thank Heather for her wonderful presentation today. I'm sure that the recording of that will go wide and far, and I look forward to my practice nurses having a look at it and thinking, I'm going to look at it again to get some hints. Because I'd love to thank Jade Buller, who's from the Workforce Development Officer at Westvic PHN, who's been instrumental in putting these sessions together and supporting us, getting us all online together, and helping us to unmute our mics and sharing screens. So thank you, Jade.
Yes, Jade.
Kerry Robertson and Nicole Bradford, the project officers of the Spider project for the Westvic PHN. What a wonderful job you guys have done, and you real credit to everyone. And I'm sure great things are ahead for everyone as we look after our patients with intellectual disability and care for them in the community. So thanks everyone, and hope everyone has a good evening and a very Merry Christmas and a safe New Year. So thank you.
Nice. Thanks, Robert.